No, just 4. Well, it's because this summer's compressed. You know, you gotta get it all in, so we don't cover things quite as thoroughly. Okay, we're going to be talking about patients with challenges, responding to patients that are on, equipment and they have other challenges. We're looking at different diseases, medical devices, abuse and neglect. We're doing. A disability, and this is a definition you need to be familiar with. A disability is a condition interfering with the ability to engage in activities of daily living. You know, if you're in a wheelchair, you have a disability, right? That interferes with your activities of daily living. It can be a developmental disability, where examples would be like cerebral palsy or Down syndrome or something of that sort, which may be developmental in nature. Or it could be due to a traumatic injury. You know, some guy, skiing and runs into a tree, or a motor vehicle accident. Or it could be a medical condition which causes it. Parkinson's, a stroke, already mentioned a brain injury. Well, actually talking about spinal injuries that can be as a result of that. You also will have patients that are they have a terminal illness, where terminal doesn't necessarily mean acute. They usually take you in hospice if you've been diagnosed that you're terminal and you've got, I think it's less than 6 months, so it is, less than 6 months. And so you're going to see a lot of these patients with a terminal illness, a chronic illness, COPD, heart failure, kidney failure. Remember we were talking about the other day about end stage, kidney disease, Huntington's, things of that sort. So you're going to have patients with those. Plus you're going to have patients that are dependent on technology. Ventilators, young children on ventilators you may see, even elderly patients on ventilators. A lot of these patients may have an advance directive. Do you remember when we were in our legal chapter what I told you about advance directives and that kind of thing? Do we care if they have an advance directive? We want to know if they have a DNR, which isn't really technically an advance directive, but advance directive really talks about their end of life, what they want to happen possibly. But all we care about is do you have a DNR or not. The rest of that stuff doesn't really matter. If they've got paperwork, you might take it with you to the hospital, but it's not going to change our care. The only thing that changes our care is if they have a DNR. Obesity, while that is not a terminal illness per se, it does increase their risk greatly for a number of different diseases. We have to take different types of steps with obese patients, particularly trying to move them can be quite challenging. But you have to recognize too that they have other greatly increased risk for respiratory disorders, things of that sort because of their size. What's going to be the most comfortable position for most of your obese patients? Sitting up. You rarely find them laying down in bed flat with one pillow behind their head. They can't breathe that way. They are going to require assistance, and you're going to require assistance in order to move them. So always make sure that you have enough people to do the job. If the patient weighs 600 pounds, it's not going to be you and your partner doing it. If they weigh 600 pounds, they're probably not moving themselves at all. So you're going to require a lot of assistance with that. You're going to have patients that are homeless, poverty-stricken patients. They're going to have different types of medical problems. Can you think of what some of those might be? Yeah. You're going to see a lot of results of poor nutrition and poor hygiene. So you're going to have what types of things? Not only they're not eating well, they're not taking care of themselves, they're probably not exercising. They also are not getting good health care, good dental care. They may require medications that they don't take. They're not able to get those. A lot of this population has mental health issues. That's why they're homeless. Substance abuse is very common in your homeless population.
Which makes no sense. You know,
Until they become homeless.
I
they
know.
spend all their money on that.
Yeah. But
Yeah.
I still do have that homework. Like, where are you getting the money to do that?
Well, you know, if I'm homeless, I don't want to just sit there and look around. I probably want to get drunk too.
That's why they tell you if you see someone begging on the streets, don't give them money, go buy them.
Give 'em
Yeah,
food,
right, go
yeah.
buy
Tuberculosis is common. Pneumonia is common. Here we're talking secondary infection. Why do we see tuberculosis commonly?
Because they live in like together.
Yeah, they kind of live in environments together like that. You know, most families, a family might live together, but you don't get large groups of people that kind of live together. And plus, they're so unhealthy that they are more prone. Autism, you are going to have some autistic children. I would like for you to do a little bit of reading on autism because we're seeing it much more commonly than we ever did before. And the behavior patterns can be very distressing for us as care providers, but they affect a lot of children. This says 1 in 91. I heard recently it was 1 in 85, and it's going down. It affects their ability to communicate. They don't communicate normally like we do. And you're also going to have a range of disorder there, where they may be highly affected to those that just have mild autism. Usually their care provider is going to be able to give you some information about, you know, how to manage them. A, B, C, S. These are your acronym to help you care for your patients with autism. Make sure that you're aware that that's a possibility. If they're acting very aggressively or you can't reason with them, there's a chance that they're autistic. So you need to be aware of the problem. Usually a care provider is going to give you that background. Keep everything very basic. With these children, you can't give them a lot of sensory input all at once. You need to tell them exactly what you're going to do and do it. Not with that. You don't need a lot of fluff going on. There's a lot of activity around there. It's very disturbing for them. So you need to be very calm, but you also have to keep yourself and your patients safe. Awareness. You may have to adapt your approach based on the ability of your patient. They do not take well to disruption in their routine. So you have to try to fit whatever you're doing in, hopefully, with their routine as best you can and not disrupt them. Don't automatically take them out of their environment to do an assessment. Try to keep things as constant as possible for them. Communication can be very difficult. We see a lot of this temper tantrum, meltdown type behavior if any part of their world has been disrupted. You know, if they're used to eating a hamburger, you know, with pickles on top arranged just like this, and now all of a sudden they get, you know, a pickle that's piled on top of the other one. As silly as that sounds to one of us, well, most of us, that can cause a major issue for a child that's autistic. So don't just blow that off. Instructions, keep them very simple, to the point, not with a lot of fluff. Your questions are going to need to be close-ended. You know, you can't ask them to describe something. It's not going to happen. Does it hurt? Where does it hurt? Point to it. Equipment, you don't need to get out everything in your bag. Use only what you absolutely have to. You know, if they've got a respiratory issue, you're probably going to need to use your stethoscope, but keep the rest of that stuff out of the way so it doesn't freak them out. Defer interventions that you would just do normally on any patient. You know, I tell you, check a blood sugar on everybody. If you've got an autistic child with an issue, don't check a blood sugar unless you think that it's related to a blood sugar issue. You know what I'm getting at here? Don't do it just because we do it for everybody. Be calm. Be empathetic, be compassionate. You know, you can't get mad just because they're freaking out and acting bad. You can't freak out too. Take your time. These are behavioral emergencies, right? We already studied that. So just take your time, be patient. We're not paid by the number of patients we see. How do I get that? Remove anything that's aggravating the child. You know, if the stack of pickles is freaking them out, let's get the pickles out of their sight so they don't see it. If it's something you're doing that's freaking them out, you need to stop doing it. Because what's your primary goal here? Treat and transport. You know, if you got to do a bunch of stuff, if you can't get vital signs, hey, you can't get vital signs. You do just what you can and then just skip the rest. You may take little breaks while you're doing your assessment. Back off, let them rest a little bit. Let them get some TLC from mom if that's what they need before you get back to doing it. You overstress them, you're going to get a meltdown. Make sure they know what you've got going on, what your agenda is. Other patients with special needs, as I said before, we're seeing patients that are living much longer due to technology. A lot of these patients used to, they wouldn't survive out of childhood. Well, now with these devices, they're able to live longer. Same thing with elderly patients. 100 years ago, you're not going to find a patient on a ventilator, so it wasn't an issue. But we're seeing it now. Who's going to be your most knowledgeable person to help you with equipment? Their caregiver. Don't be embarrassed to ask them to explain something to you. They're going to know those things inside and outside, but you know how to manage a patient with, ABC issues, right? Always ask them. Same thing if you're doing an assessment on a patient. If it's an equipment issue, has this happened before? What did you do? How did you fix it? It's something that you may be able to do if you have any ability along those lines. Have you tried to fix it? What happened when you did that? You want to find out how they normally move the patient. A lot of these patients that are on equipment, if you can just fix their equipment issue, then they may not need transport. They may be in a chronically vegetative state. If it's chronic and there's no change there, it's just an equipment issue, you may have to transport them for equipment issue if you can't get that fixed. But say if you've got a patient on a ventilator and the ventilator is not working and you can't fix it, what are you going to do? You're going to use your bag valve mask. That's what you're trained to do. They can't breathe, we use a bag valve mask. So no big thing there. Talk to your patient. Ask them questions. Like here, this lady's able to speak, I believe, with difficulty, but get information from them if that's where you need to get it. Follow your protocols. Oh, I said some of those. If you have the ability to fix a device, then you may leave the patient in place and not transport. Would you transport a ventilator with a patient if it's not working? No, don't need it. It's not working. You can use a bag valve mask and then make sure that the hospital, they know it's a problem, so they'll get it fixed. Boy, I must have been like really tired one day. What is important to do with an autistic child who is escalating? Take a break, back off, be calm, remove anything that's aggravating the patient. What would be the most important question to ask yourself when a medical device fails? Do what? Yeah, is it life-threatening? Do you need to step in and do ABCs? Is it something that can be easily fixed? How do you fix it? Okay, different diseases. We've talked about most of these already, I think. With handicapped patients, it may be a congenital issue. Congenital means it was something that was present at birth, versus acquired is something that they acquired or got after they were born. Good. Somebody else must have done this. Examples of congenital: cleft palate, they're born deaf, have a congenital heart problem. Acquired, this would be some of your elderly patients. They got COPD or got AIDS or a traumatic injury of some sort where it came about later in life or after birth at some point. If they've got a chronic disease, they may have an acute exacerbation of it where it becomes worse. Okay, medical devices. I'm going to try to remember to bring some of this stuff out in the lab so you can see it. CPAP is something that a lot of your patients may be on. They don't require around-the-clock CPAP typically, but when did we talk about that we might want to use a CPAP on a patient? Specifically, I told you one time. Yeah, and what's the condition of fluid in the lungs? Pulmonary edema. So if you've got a patient with acute pulmonary edema, as an EMT, you're not going to have access to CPAP, but the advanced students do, and the paramedics do, so I'm going to be calling for some backup. tracheostomy tubes. This is a tracheostomy, or like a tracheostomy tube. This fits in the, what do you call that little hole here? The stoma. And it'll fit in there, and we haven't looked at ET tubes yet, but I hope we'll get to that in the next couple of weeks so I can show those to you. This really is just a small part of a ET tube. So this will slide down into the trachea towards the lungs. What's this flange for? Yeah, keeps it from falling down the hole. Yeah, this has an adapter on there where you can attach a bag valve mask directly to this, and you can bag your patient. You can also put a non-rebreather, a pediatric non-rebreather, on the neck over this, so that you basically give them a non-rebreather. Now, could you give them a nasal cannula with this? Not so much. Okay, just checking. Now, a patient that has a tracheostomy, and they may have one of these, it may be temporary or it may be permanent. So you may have a patient with a hole in their neck, they have a stoma here, but they also are breathing through their nose and mouth as well as through the hole. So it may be a situation where they had to have an emergency trach, and they're going to heal it up once their other issues are fixed. So if you have to ventilate, if you're ventilating a patient, how are they receiving oxygen? A bag valve mask. You're not ventilating a patient through a non-rebreather, right? They're breathing on their own. So if you're ventilating them, then you're using a bag valve mask. So if you try to ventilate through this stoma, how are you going to position the head?
Neutral.
Yeah, just neutral. You don't have to tip the head back because we're not worried about the upper airway. You just keep it neutral. What if you're ventilating and you don't see any chest rise? Do what? If you're breathing through here, you may have to suction. There may be something blocking that, certainly. What if you're ventilating and the bag's going down really good, but the chest not rising? Yep, it's probably coming out the nose and mouth. So if that's the case, what are you going to do? Do what? Yeah, I mean, which is going to be easier? Yeah, plug the hole, put something over the stoma, and ventilate through the nose and mouth, over the mouth area. Okay, CPAP, y'all probably all seen this, have you? Seen the CPAP? Some guys on that. What is it that the CPAP does that helps the patient? That continuous pressure, how does that help the patient? Yep, it splits the alveoli open. For the guys with sleep apnea, it just keeps that constant airway pressure in there so that the lungs stay partially inflated, the alveoli they're splinted open. Now we use this for our pulmonary edema patients. How does that work? Kind of pushes the fluid, that pressure pushes the fluid back into the vascular system, yeah. Usually when we transport a patient, the problem is something other than their equipment. So sometimes we may transport with equipment depending on what the equipment is. Make sure if you're bringing in a patient with equipment that they know. For instance, if you've got a ventilator patient at home and the ventilator's not functioning, you're having to bag your patient, you want to make sure that they know when you call in that they're going to require a ventilator, because those nurses don't want to sit there and bag that patient for, hour after hour. So make sure they know they need a ventilator in the ER. I told you that. Mucus builds up. So very frequently, you're going to have to suction these stomas. They've got a tracheostomy. Probably the first thing you're going to be doing is suctioning. And if you go on in the program, you will have a respiratory clinical rotations where you'll work on this. They may or may not be able to speak. Check the tube. Use a whistle tip or a soft, flexible catheter, also known as a French catheter. They're small, and we use these for pediatrics to suction the nose and the mouth sometimes, but we'll use it to clear a stoma. When you're suctioning their stoma, you're sucking the air right out of their lungs with that. So you want to be very careful you don't over suction, but it may freak your patient out a little bit. You may need to ventilate them. When you're transporting, Try not to transport them completely flat. You want to tip their head up a little bit to help that drainage. Ventilators. The tube may also get mucus buildup in there. Make sure your BVM is attached to oxygen. Cardiac devices. A lot of your patients are going to have some type of implanted defibrillator or a pacemaker. And over the last few years, they have created so many different types of devices. There's no way that you're really going to be familiar with everything out there. So don't be afraid to ask your patient what they have. They may have an implanted pacemaker. What the pacemaker does is it just provides that pulse. It provides that impulse to cause a contraction of the heart. But these patients, it's an electrical issue where their SA nodes probably not functioning properly, or any one of the other nodes are not functioning properly. Those are usually automatic, got the pacemaker, and the pacemaker is going to be set usually at a certain level. Like I mentioned earlier, if you have a patient that doesn't become shocky, they're not able to become tachycardic because they got a pacemaker that's set at 65 or 70. So they're not going to be able to become tachycardic. The heart just can't do that. They might also have an implanted defibrillator. If you had a patient that has gone into cardiac arrest before, it's a good chance they'll put a defibrillator in there. If they have a patient that goes into ventricular tachycardia, then they may implant a overdrive cardiac defibrillator in there. So a lot of your patients may have that, AICD. They may have a LVAD, which is a left ventricular assist device. The left ventricle is what? The largest, the workhorse of the heart. And if it's failing, if the patient's had several heart attacks, they may have so much dead tissue in there that it just really can't contract well. In that event, they're going to put a device. You can see this device. This is outside of the chest. They'll put a device that functions like the left ventricle. And the blood comes out, it goes through here, and it acts like a contraction, a pump, and it's pumped back to the aorta. That's how it goes, yeah. So it's coming back from the lungs here. So they're going to carry this on a pouch, usually outside their under their clothes or something. A lot of these patients are waiting on a heart transplant. This is a picture of an implanted pacemaker. You won't see this. This is what it looks like on an x-ray. But you will see, I think I have a picture here. See, you can see it under the chest right here. You can see he's had open heart surgery. It's one of the things you're going to be looking for. You ask your patient, have you got any cardiac problems? And they go, no. And you're putting on the little 3 leads, and you look, and he's got like this zipper down the chest. It's like, well, really? What, did somebody stab you 50 times? That's rude, sorry. AICD, they're going to have an implanted device, usually in the upper left part of the chest. Oh, this is the AICD. It's going to be completely implanted. It may also look like that pacemaker, so you may just ask them. But what it does, it acts like a cardiac monitor, and it will assess for and read kind of like an AED does. And if it detects a lethal rhythm coming up, then it's going to shock the patient. This saved a lot of lives with that darn thing. Delivers a shock to correct or fix the dysrhythmia. Now, it is painful to the patient. They know their defibrillator's gone off, and it can freak them out. Sometimes it may go off repeatedly, and what that means is if I didn't have this implanted defibrillator, I would be what? Dead. Yeah, DRT, exactly. So that kind of freaks them out. But know that shock that's shocking them will not shock you. It's not going to affect you in any way. You can't even feel it. But your patient will tell you that he's being shocked and it's freaking him out. How are you going to treat that? Your patient's being shocked by an implanted defibrillator. Is it going to vary your care? Not a bit. Still going to do the same things. Now you may want to request ALS backup because that patient may be receiving that shock, but it really is no different than an AED. Do all your patients shocked with an AED make it? No. So this patient may keep getting those shocks, but it doesn't matter. He's in a lethal rhythm and he may die. So they may be working a code on that patient. So they are a high-risk cardiac patient. If they didn't have that device, they'd be dead. But just because you're getting the electrical activity, just because you're getting that electrical stimulus, doesn't mean that the heart's going to contract. So they may not make it. Oxygen reassessment. If they go in cardiac arrest, you can do it just like any other cardiac arrest patient. Just don't put your pads right over that defibrillator. Left ventricular assist device. See this little guy? I had trouble finding a good picture. He carries this thing around with him all the time because the blood's coming out, is circulating through his little pump, and is going back into the body. He looks nice and pink though. It must be working well. Things that can go wrong with that, they can have battery failure. They may have to plug that in. They may be out in a park somewhere and they didn't charge it before they left. I think we have little plugs we can charge them en route. They usually will have some kind of a hand pump or a foot pump that can do it. Just like we can bag a patient when their ventilator breaks down, they probably have some type of device they carry with them where you can actually, how many times are you going to compress that darn thing? 60 to 70 times a minute probably. A foot pump would be a lot better. Alright. Gastrourinary. You may have patients with feeding tubes, urinary catheters, ostomy bags. These are very common. You're going to come across patients with these things. Usually your patient and the caregiver is going to be your best resource for how all these things work, what they are. Don't be embarrassed to ask them what that thing is. There's so many different things out there. This is a little feeding tube. You can see that she's got the little food in there. What do you think, what types of problems do you think can happen here? It can get infected. Is that what you said, Bo? It can get infection. It can be disrupted. It can be bleeding. Certainly. G-tube, this is where the tube actually is going to go into the abdomen to feed. If you have to transport a patient with one of these, make sure you secure the device. Go ahead and tape it down or put an elastic band or something around to hold it in place when you transport. You don't want anything to pull that thing out. If they're being fed and you're transporting, make sure you keep that higher than the patient, because anything you put down, you're going to get an auto transfusion going the wrong way. Urinary catheters. A lot of your patients will have some type of indwelling catheter. In this case, you can see this is a urinary bag here, and then he's got a catheter. You can see the urine builds up here. One of the things you want to notice is what that urine looks like. If it looks really bad, your patient's probably really bad. If it's nice and clear, then that's probably good. But same thing here. You can have the same issues. You can get irritations, you can get infections, it can be pulled, and you can have bleeding, that sort of thing. When you transport a patient with this, make sure this stays higher or lower than the patient? Lower. Particularly if this is nasty. You don't want to like send this back into the patient. So it's always going to remain lower. Before you move this patient, you want to make sure you put a clamp on it. Remember on our IV catheters, our IV tubing last week, or whenever that was, we had some clamps. Make sure you clamp that so you don't get movement back and forth. If this bag is very full, well, I like to dump them before I transport a patient. So if there's somebody there, you might ask them, go back, go back. That was quick. Man, I'm not good. You may ask them to go ahead and empty that before you leave. Bag lower, document the color. Look at the amount also, what was in there, because they may want to know that in the emergency department. Thing says empty it. If it's a third or half full, I'm letting it go. Make sure you document how much you dumped out. Ostomy bags. You can see this little picture right here. It's attached to the outside here at the ostomy area. May have an ileostomy or colostomy. You're not usually going to see this. They're going to have on bulky clothing most likely. Same problems. You can get irritation or infection at the site. Something may become blocked in there so it's not moving at all, and that can cause a lot of abdominal issues for your patient. Make sure that you secure that bag so that it's not pulled away from your patient in any way. We talked at length about dialysis patients the other day, so I'm going to go through this fairly quickly. Patients that go to dialysis have renal failure, right? And what exactly is renal failure? Kidney failure, that's right. So dialysis kind of does what the kidneys are supposed to do, but it's not very good at it. Hemodialysis and peritoneal dialysis. Which one are most of your patients doing? Hemodialysis. Where does hemodialysis occur? At a dialysis center. This is kind of what these little ports look like in the arm. Remember I told you don't want to take a blood pressure on that arm. You don't want to do anything that may disrupt the site at all. So you can have complications here. You can have bleeding. You can have infection. What's the problem with if this starts to bleed on these patients? They keep bleeding because, yeah, they're probably on blood thinners here just to prevent them from getting blood clots. And so they very frequently have bleeding issues. Peritoneal dialysis, so they're going to insert fluid through the abdomen, clean that out, and then it's going to be sucked out. We talked about that. Same complications, go back. Infection, dislodging of the catheter, that sort of thing. I already told you that. I mentioned they may have significant blood loss. How do we treat blood bleeding? Direct pressure, pressure bandage, elevation, last tourniquet. Yep. Same thing. You're going to treat these patients for shock. They're losing a lot of blood, you know. Regardless of the cause, you're going to treat them the same way. They may have central catheters, central IV catheters that are there for long-term delivery of medications or fluids. PICC, PICC line, peripherally inserted central catheter. Usually we're going to find these in the arm. Typically, they may have a central line, a central venous line. These are usually going to be subclavian, around the jugular in this area, or it may be femoral. They may have an implanted port, which looks kind of like that defibrillator that we saw. So it's going to be implanted. You'll see a little hump there. Those are going to require a special kind of needle to access. So we're not going to be accessing those in the field generally. Most common complication is going to be infection at the site. It may be bleeding. Central lines, only hospital personnel are going to access those. Be careful you don't tug it or dislodge it in any way. Other physical impairments that your patient may have, any one of the senses. They may have difficulty in hearing, seeing, mobility issues. Approach each patient as an individual, find out what their deficits are, and then work around those. Physical impairment does not mean mental impairment. You know, if you've got somebody in a wheelchair, don't stand behind them and talk to somebody else about the patient. You know, they probably hear just fine. So be very careful with that. Shocks me to see that. If a patient has a guide dog, the guide dog can ride with you in the ambulance. So they are very highly trained. It's not a problem, so you can't say no to guide dogs. When you're doing your assessment, you want to know what they are normally and then what's acute onset. Make sure you explain to your patients what you're doing. If they're in any type of compromised position, they're handicapped, challenged in any way, they need to know what's going on. So make sure you tell them what you're doing. You don't want to scare them. If the patient has some particular aid that they need, go ahead and transport. That doesn't mean I wouldn't take a walker with them because they're going to be riding on your stretcher. But anything else that they require, like the guy with the left ventricular assist device, I'm going to make sure I'm taking that with him. This is a vulnerable population. Anybody that's on any type of equipment, any of your special patients that make any of their equipment that makes them dependent, they're vulnerable. So you've got to keep an eye out for any type of abuse. Maybe children, it may be adults, but elderly are specifically vulnerable. What to look for? if you get different stories about what's going on, particularly with a child, you know, they say one thing, family says something else, that's going to be an indication of that you may have a problem. Multiple injuries in various stages of healing, repeated injuries, you know, in the same area. If the caregiver seems indifferent to the patient, you know, you'd think if you're abusing somebody, at least you'd act attentive, you know, when EMS comes, but you'd be surprised that it doesn't happen. Be careful that you don't accuse the caregiver or the parents at that time. The abuse may be coming from outside of that central area, so don't accuse. But that's only going to make matters worse. You want them to consent for you transporting whoever it is, so you can't start accusing and get confrontational. You want to get the patient out of the environment. Once you get them to the emergency department, they can call in all the help that they need. Your job is patient care. So you get them out of the situation, get them transported. And then at the emergency department, you report any of your suspicions, but be prepared to substantiate that with, you know, well, this is what I saw, this is what was happening. How does your approach in cases of possible abuse or neglect differ from your approach in other cases? Sometimes you may transport a patient that medically doesn't require transport because you're worried, you know, about them being injured or something. Get the patient and yourself out of the environment. Remember the definition of a disability. Recognize that your homeless population, your poor, your obese, they have increased health risks that you need to be aware of. Rely on caregivers and parents for their expertise with any special equipment that the patient may be on.
How do they diagnose someone with autism? Is that going to be like a chemical thing? Or
I'm sorry, I didn't hear.
how do they diagnose someone with autism? Is it a chemical thing? Or
You know, that's a good question. Honestly, and some of you guys may know more than me. I think oftentimes it's based on behavior, you know, presentation, what they see, patient's response. Do what?
I think
yeah,
people
that's why
overdiagnose it.
I asked, honestly.
What, blood tests and stuff? Is that what you're saying?
Well, no, I'm saying that some kids might be diagnosed autistic and it's just their parents babying them, whereas other kids actually have it.
Yeah.
Oh, well, certainly, certainly. In fact, it's interesting that you said that because I'm going to tell this really quick. I heard and did some reading recently that they have some idea that some of this ADD that they're treating patients for is not ADD, but it's actually a staph infection that's causing these behavioral abnormalities. It's very interesting. You ought to do some reading on that. So a lot of kids that they've tested, they put them on a long-term antibiotic to actually kill that staph because it's not going away, or it's not staph, strep, similar. A strep infection, but they're not showing signs of strep throat. But it's that low level of strep in their bodies causing these severe behavioral abnormalities. And somebody on our staff here has been dealing with that with a child, and they put them on antibiotics, and it's been this huge change in behavior. So it's very interesting. So yeah, I think there's a lot of that stuff out there that there's other issues that they just attribute. But
How do they know to test them for that? I mean, is that now parents' job to go, hey, you might want to test my child for strep?
well, usually, yeah, you do have to do that. You know, unless you've got somebody that's really in the literature and they're paying attention. This particular family saw several physicians before they wound up with one that said, you know what, I've had 5 patients in the last year that presented like this, and it was a strep involvement. You know, they did the strep test, there it was, but they didn't have the strep throat and that kind of thing. So, anyway, interesting. Already said that. Said that.
I also wonder if, like, people with more children are getting autism because there's more people in this world. You know? And if medical
I'm sure there's something environmental in there. I would have to think.
It makes me wonder. if
Yeah, the
it's
ratio, you're right, there the ratio is much tighter.
Right.
I've seen some stuff where they're trying to say that a lot of them are coming from the not reacting well to vaccines they get when they're young.
You know, they keep saying that, but they can't,
Yeah.
they haven't proven anything along those lines. And, but there's something out there, but, What does ABCS stand for? Aware, basic, common sense. Good work. One more. What does a CPAP machine do? Provides continuous air pressure. It does what? It splits open the alveoli. Can a responder be injured by an AICD that discharges? No. Okay, you're called to transport a ventilator patient. As you begin your survey, the ventilator stops functioning. What transport considerations do you have? You going to transport them? You taking the ventilator? Don't need it. Yeah. Do what? Oh yeah, I have one here. It's a clicker thing, but there was none in there. Shame on me.
I was